Now we will go to our first case scenario. So here comes a 50-year-old lady, so elderly and presented with severe headache. She has a severe headache for 1 to 2 months and sudden onset of seizures. So severe headache, okay, and sudden onset of seizures. Both indicate that there is a problem with the central nervous system. CT scan shows a large heterogeneous mark in the frontal lobe of the brain. So there is a large mass in the frontal lobe. So if you take the age that she is a 50-year-old lady who has severe headache of sudden onset, and then she has a large frontal mass, or you can have a large mass in the frontal lobe, the most likely diagnosis is a glioma, which is the most common tumor, accounting to say 60 to 75% of CNS tumor. So if you think of a tumor, the most common is glioma, so she is likely to have a glial tumor. It could be most likely a astrocytoma. Less commonly oligodendroglioma, or it could be ependymoma, but because of the location that it is in the frontal lobe, which is the most common site for astrocytomas, so she is most likely to be suffering from a glial tumor, that is astrocytoma. So what is the most likely diagnosis? So she is suffering from a glial tumor, and that is astrocytoma. Now astrocytoma can be grade low grade or they can be high grade. Okay, or astrocytoma can be low, that is grade 2, high grade is 3, and 4 is GBM or glioblastoma multiforme, and we will learn about these tumors, each of them, in our subsequent slides. What is the pathogenesis of such a lesion we will see, and what are the histopathological changes expected in the biopsy also we will be learning in our subsequent slides. So before we go to the tumors, let's have a note on what are the normal cells in the central nervous system. So the cells are derived from the neuroectodermal, or they are neuroectodermal in origin. The first or the most common cells are neurons. They are large cells. Okay, the neurons are large cells, but tumors coming from neurons are less common. Whereas the second is the neuroglia, and the tumor coming from neuroglia are called as glioma, and they are the most common tumor category. Okay, and then they have astrocyte, which is present in the gray and white matter, and their work is to support the neurons. We have oligodendrocyte, which are present in the white matter, and their function is myelination. Whereas the ependymal cells, they lie in the ventricles, and they are associated with the CSF or secretion of CSF. Okay, so each type of cell, astrocyte, oligodendrocyte, as well as ependymal cell, and they all belong to a broader category, that is neuroglial cell, and the tumor coming of neuroglial cell is broadly called as glioma. Next, we move on to the microglial cells, which are the macrophages, and these macrophages are a source of infection in HIV patients, or you can say the HIV virus affects these microglial cells and forms microglial nodules. Okay, we do not have any tumors coming from the microglial cells. Then comes the mesodermal derivative, that is cells of the meninges, and from the meninges we can have a tumor that is called as meningioma. Okay, we can have meningioma coming from the meninges. So these are the normal cells. Now we will progress towards the brain tumors, or what is the classification of brain tumors. Now brain tumor incidence is 10 to 17 per lakh population, and there are certain unique features of brain tumors which are not seen in other tumors, or in tumors that are seen in other sites. For example, there is no detectable pre-malignant or in situ changes. When we talk about carcinoma, in Morse carcinoma, there is a pre-malignant in situ lesion. In situ means the basement membrane is intact. Okay, so dysplasia with intact basement membrane is called in situ, and in this in situ are pre-malignant, but in CNS tumor we do not have any pre-malignant or in situ stage. Next comes anatomic site of the neoplasm decides the symptoms or the outcome. In other sites we know the benign nature or malignant nature of the carcinoma decides whether or how it will behave, but here the anatomic site of the neoplasm decides. For example, meningioma is a very benign and grade 1 tumor, but once it is located in the medullary region which is responsible for our respiration, this can cause respiratory arrest because of pressure effect. And once they are located in the medullary region, taking out these tumors totally, the resectability is little bit difficult in such locations without harming the normal brain tissue. The other thing, they rarely spread outside the CNS. Now outside tumor, like we know, carcinoma can metastasize or they can have mets to the brain. Okay, CNS metastasis, but CNS tumor do not go outside the brain. Then the limited resectability, like in other sites we can take out the organ or we can remove the organ, but in brain tumors the resectability is a question because some tumors, like I said, a meningioma arising to the medullary region will be very difficult to take out in total, and then it can cause during the surgery there can be injury or harm to the medullary or normal medullary lesion. That is why the possibility of limited resectability.